So, Huntington's disease is an autosomal dominant neurological disorder. So, when I say autosomal dominant, it means that if either of your parents has a mutation, the offspring is likely to can inherit the disorder. So, there's a 50% chance that any child of a Huntington's disease patient will inherit this mutation. So there is a there's a gene called Huntington in our uh, cells, which is on the fourth chromosome, and within this, the exon one, that is the coding region of the gene, there is a long strip of polyglutamine, which is coded by a nucleotide repeat CAG. So in all of us, there is this CAG repeat. But when the number of repeats exceeds 39 repeats, that is, you have CAG, 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 CAG going on, and when it becomes more than 39, it becomes pathogenic. That is, the protein that is formed is not doing its job properly, and people start developing symptoms. So the nature of this mutation is such that it is what is called as dynamic, and therefore, when it is inherited from one generation to the other, there is a chance for this mutation to get worse. And so often, patients would develop symptoms earlier or more severe than what their parents had. And there are three components to this illness: there is a neurology, there's a psychiatry, and there is also a cognitive component. So some patients start with, most patients, in fact, I would say, start with the neurological component, which is called chorea. There is, which is sort of a dancing, uncontrolled movement of the body, and this is kind of typical. So most of the time, if somebody presents to a neurologist with these choreoformic movements, and they say yes, there was something like this in the previous generation, the doctor immediately says, okay, let's test for HD. The other thing is these patients also have psychiatric symptoms. That is, they have like schizophrenia like symptoms. They are imagining things, they are suspicious, and some of them have a lot of anger outbursts. So often patients actually go to a psychiatrist first, and sometimes the fact that this may be HD is completely missed for a very long time till the movements start appearing. And these patients also have cognitive issues. That is, slowly there's a dementia like thing and decision making problems and all of that. So there are three facets to the illness itself. Because this illness does not start in infancy, in most cases it will start around middle age, around 35 to 40. At this point, most people would have had children if they did not suspect that they have a genetic condition. The neurological symptoms that I first mentioned. So it includes some ataxia, some dysarthria, and some movements. So in layman terms, I would say that it's like a person kind of keeps on doing a certain movement, and it is done in a certain way, which is a very classic Huntington disease kind of a choreoform movement. That is one. The other thing is that as the disease progresses, there is slurring of speech. So, very often people with this kind of a problem are mistaken that they have under the influence of alcohol because they have a drunken kind of gait and their speech is not clear and they are not able to control their movement. So let's say somebody is in a bus and you may inadvertently touch somebody without meaning to, and those kind of things have caused problems for patients. They have been thrown out of a moving bus because somebody thought they were being inappropriate. So it's kind of uncontrolled motor movements, let me say, and so that influences swallowing and influences speech. On the psychiatry side, there is suspicion, there's tendency to keep repeating yourself either in speech or some activity, a slightly OCD like behavior. Then there are a lot of anger outbursts. There has been reports that there is more suicide in families with HD. There can be, of course, depression. And as far as the cognitive symptoms are concerned, patients sort of have problems taking decisions. They kind of become, they have to be managed like a child, and slowly dementia like behavior sets in. Now, I've mentioned all these three, but the but the proportion of these three aspects and the progression varies a lot in every individual across generations and even siblings. So, to what extent the other genetic background of the individual, the lifestyle, the diet, and overall daily activities that a person carries out, all of this contribute. So, it's not like the moment you get a report of HD, it doesn't mean that your life the next 5 years is already decided. It's a lot in your control on how you can kind of manage yourself. Yeah, so there have been instances, I would say not very common, but there have been instances when somebody has been treated for schizophrenia for several years, in fact, before any movement came in, and therefore the patient was not suspected at all. And the first time some motor symptoms crept in, the physician picked it up. Or of course when there is family history, and so therefore it's always a good idea for a physician to ask for family history, that is there any brain disorder, any neurological problem in your family, so that you get an inkling of whether there is something else going on as well. The other problem here is that many of the, especially the earlier antipsychotics that were used to treat patients of, say, schizophrenia, they also develop a kind of movement problem, which is called tardive dyskinesia, which is a side effect of some of these medications. And that also causes a kind of rocking movement of the head and things like that. So sometimes a physician may get, a little confused. Let's say you've gone to one doctor for 5 years, and then you go to another city and you go to another doctor, and now that person may think, oh, she has been taking treatment now for 5 years, and therefore these may be side effects of the medication, but actually it could be HD. So a little care has to be taken into what is the kind of movement the patient is showing. If there is something like a uh, coriform movement, and the test is very simple. There's a genetic test that is there, which is very definitive. So there is no doubt about it. And there are several centers, including NIMANS, where the test is done. So it's not a very difficult to do test. So any suspected HD case definitely should be given for, should be sent for genetic testing. So the role of the caregiver is very, very crucial in Huntington's disease. So the caregiver uh, can be a parent, can be a spouse, or can be a son or daughter, or a sibling. So in all of these things, see, when the person who is the caregiver is at risk himself, so it's when it's a child or it's a sibling, they would have already seen some family member who's gone through it, so they know sort of what this disease means and what is likely going to happen to this patient, so they're sort of mentally prepared. When it is a spouse who has no idea of what this disease is, sometimes it becomes more difficult to manage. Now, nobody actually dies of Huntington's disease itself. The disease causes problems in movement, causes problem in swallowing, communication. People fall very often, and then because there is swallowing problem, there is a tendency to for the food to go into the food pipe, because of which there are complications of pneumonia, etc. Falls lead to fractures, and then the person becomes bedbound. So a lot of it is patient management, in the sense that if you provide your patient a good atmosphere, first of all, a positive atmosphere at home, that this is not a terrible thing that has happened, we can deal with it. Second thing is the nutrition. Now, most of us, we would like to take 1 gram protein per body weight, let's say. For a HD patient, because there is so much of continuous movement, it's very important that a high calorific diet, high protein diet is important. So, like almost 1.5 grams per body weight would be good. And then also a very rich diet of carbohydrate and fat. The reason being that because so much of energy is constantly being expended, because their hands and legs are constantly moving, and that expends a lot of energy. So what you would say is probably unhealthy for a middle-aged adult is very good for an HD patient. What is crucial is that because they have problems swallowing, often they may eat a little bit and then they start coughing and they get frustrated and say, okay, I'm done, I don't want to eat anymore. So they have to be given food in the right kind of consistency which they are able to handle. So most patients find it difficult to drink milk, like something which is very liquid. But something which is a semi solid porridge or ganji consistency is easier to handle. So, whatever works for the patient is what should be given. And secondly, the patient should focus on eating while eating, not be watching TV and trying to eat at the same time. Because this is a concerted activity which requires attention for a patient. And therefore, there's a chance of choking and things like that. Never try to drink water from the top like that. Use a straw or just sip. So these are small things which prevent more serious complications, because if your food goes into the food pipe, then there are complications of choking and pneumonia and all of that, which we want to avoid. Another thing is, because of these movements, they tend to fall, or they tend to hit their head on furniture. So a lot of patients use a helmet even within the house, even when they're not driving or anything like that, so that even if there is a fall, there is no cut or no abrasion on the face. So that is something which is available and is used. So that is one thing. So basically, if you try to prevent falls, control nutrition, maintain a good diet, and try to maintain a positive atmosphere, you can keep going for a long time. People have maintained their jobs and kept working and been functioning up to 60 and more. So it's not like, okay, I have to pack up now, I have this and I can't do anything more. So that is not an attitude that should be encouraged. Yeah, so as far as the patient is concerned, it requires a lot of courage. It's very well for us to say that you should go out and not um, try to hide. Just the other day, there was a young man who had come from a village, and he says that he is studying in a college which is some 15, 20 kilometers away. He takes public transport, and he says, everybody in the village makes fun of me. And even at school, at college, I don't talk to anybody. I just go do my work and I come back, because society in general somehow can handle a diagnosis of diabetes or even cancer maybe, but somehow the moment the brain is involved, people somehow feel that the patient himself or herself is responsible for that condition, which is really a very unfair thing. So the first thing is they think you're drunk, which is very sad. So increased public awareness is very, very important, but they have to be very stoic about it and have to deal with it. That they can, hopefully they will have a set of friends that who will not kind of ridicule them. So there is this. First, you have to deal that you yourself have this condition, and then you're afraid that your kids might have also have got it from you. So it is indeed a very difficult situation, and therefore patient support groups are very, very useful. So uh, the patients have themselves come up with something called as HD Care, which is a WhatsApp group that has been set up. And we encourage patient families, caregivers, or patients themselves who are symptomatic, asymptomatic, to participate, because often patient families put up their grievances. Somebody says, I'm in so and so city, I don't know, do you know any doctor here, or my mother is just not listening to me, I'm frustrated. So there are, it helps a lot to ventilate your anxiety, and often very helpful suggestions comes in from other people who are in the same state as you. So it's important to keep a positive attitude and try and help the whole thing. So abroad, the HD patients group has been very, very proactive. HD is very common for some reason in Western Europe and in some parts of South America. So there are many patient active groups which are very, very proactive, and they are the ones who have actually uh, contributed to research. So there are a lot of uh, cohort studies ongoing to understand the disease, where families can participate, provide samples, etc., etc., etc. So if we have a coherent group of Huntington disease families in India, it becomes easier to uh, make progress, to ask the government, these are our problems, how can you support. It will help researchers who are trying to understand this disease better. There are a lot of drug trials going on all over the world, actually, and therefore if we have a structured situation where we have a patient registry of HD, and we say, okay, these are the people who have Huntington's disease in India, this is their profile. Going forward, these kind of companies will come forward and say, okay, maybe I can start a drug trial in India too, because there seem to be enough patients here. Right now there is no HD registry of HD patients in India. From our own estimates, we think that there may be 3 to 4 people with HD per lakh in India, and which translates to almost 85,000 or 60,000 individuals with Huntington's disease. We know in our own center we have tested almost 400 patients, and similar numbers from other parts of the country. So at least 3,000 people have been tested positive for Huntington's disease, we know for a fact. So as you would imagine, if one person is having Huntington's disease, that means that parents, siblings, and children, so maybe 2 or 3 or more people in that particular family also may have HD. So there are people there. It is not a super rare condition. We do get patients coming at fairly regular intervals to NIMHANS, and so it is something that requires work, awareness, etc. Yeah, so I would say that I would reiterate the importance again of setting up an HD registry, so that all aspects of Indian patients, their clinical symptoms and their presentations, progressions, etc., can be documented. This kind of information, when available, will help other physicians who are treating them in India. And having a central directory where all doctors who can treat this condition, so that if any patient wants to see somebody in a particular city, can approach them. We try to do that in HDSI to some extent, but we've not been very successful as yet. But from our own personal contacts of physicians, we have tried. So when somebody says I'm in so and so city, we try to direct them to a nearest hospital. So that is a very crucial thing, because often patients need continuous support, and not many centers have that time and the right qualification of people to do that. So that is a big problem. Physiotherapy is important. So there are certain exercises that help with balance and uh, prevention of falls, um, swallowing, etc., which is a very important aspect. So right now, I would start with management, because somebody already has a disease, has to deal with it. So often, if a patient goes to a neurologist, and they know that this is the diagnosis, they will tell you that yes, you have Huntington's disease and you have to deal with it. But the fact is that the patient family has to take care of this patient for the rest of whatever 15, 20, or whatever years that the person is going to live, and has to deal with all the challenges that come with this illness. And therefore patient management is a very important part of this. So they need help with nutrition, physiotherapy, speech, swallowing, exercise, and in addition, the regular clinical care that they would need for their movements or their psychiatric manifestation that they might have. So patient management comes first. The second thing I would say is that public awareness, um, that people should be a little more sensitized to feelings of people like this. Often they only have a physical condition, but they are cognitively and mentally quite fine, and therefore if you were to react very adversely, it hurts them a lot, because finally they are also intelligent human beings like you and me. There's nothing very mentally wrong with them. They are completely fine. So getting over the social stigma is very important. In villages, families have been kind of thrown out of the village because they said there is some spirit that has overcome this family, and it's going to spread into the village and things like that. So uh, illiteracy has its own problems, but it's not as if the literate population has been very nice to them either, because even in an urban situation, they have been ill treated. If they want to get onto a flight, there is a problem. If they want to get into a bus, they have a problem. So these are things that need sensitization. If public awareness improves, policy can be definitely handled. See, the thing is that, for example, if they were to declare that they have a genetic condition, they will not be able to apply for insurance. So even if you're being treated for a fracture, which has nothing to do with Huntington's disease per se, anybody can get a fracture or have to go through a surgery of that kind. That will not be covered by insurance simply because you have declared that you have Huntington's disease. And therefore, people would obviously hesitate to declare that condition because uh, they want to be able to use insurance. So these are some very complex issues that are there. We need some kind of a help line for these people, so that, because they require different kinds of help at different times. So somebody may have a dental problem, somebody has a fracture that needs to be fixed. You can't take an x-ray because the person is moving constantly. So these some of these are very technical problems which an average clinical setup may not be able to deal with. So they need some specialist support of different kinds on and off. So if something like that can be provided, I think their lives would be helped a lot. And not everybody lives in a tier 1 city. So going to a hospital that can understand the problem and treat is also a problem, because over time these individuals cannot just get into a bus or take public transport and keep going for follow-ups. So usually you will see the patient in the initial stages when they are kind of still mobile and they are able to communicate, but as the illness gets worse, they are confined to their homes, and depending on the uh, proactive, or the ability of the caregiver, they will get help or not. So as part of the HDSI, that is the Huntington Disease Society India, this was an organization that we set up on the behest of the families. They said, you've been doing so much in immense, sir, you must come and help us set this up. So it was set up a couple of years ago, and it's now a registered body. So as part of this, we have been trying to have some physical group meetings like a seminar workshop. Some online meetings have happened where we call experts who explain about the illness. So there have been donors who have donated money and said that we can use it to help poor patients who need help, because one is medication, or we travel to the doctor or whatever it may be. So those are some of the activities that we've been doing under HDSI. So one of the main problems in HD is that as the disease progresses, the person kind of wastes away. You don't see any muscle mass; it becomes just skin and bones as time passes, because because of the movement, a lot of energy goes into it. You may not be a marathon runner, but sitting in one place, your muscles are constantly moving, and so that uses up a lot of energy. So it's important that a good calorific diet is given, and we have seen that patients who are able to manage that, they are able to maintain some muscle mass, and that definitely helps them to stay relatively well for a longer period of time. So controlling the diet and managing that, making sure that it is a well balanced diet with adequate protein and fat and carbohydrate, is very important, because like I said, many of them find it difficult to, they may not relish the meal, and because of their movements, it is a very messy process of eating, so food is going to fall here and there. For them, it is frustrating as the disease progresses, that they just can't take a spoon and put it into their mouth. So it has to be a very patient activity with caregiver and patient, and say that okay, this is something I have to do so that I stay well for longer. So they have to take it as a challenge and say, okay, I'm going to eat slowly, but I'm going to do this. I will make sure that I finish whatever is there in this cup. So it is an effort on both sides for the caregivers to make it appetizing. Sometimes patient may be very unreasonable and ask for something which is not possible. So they're known to sometimes be very, what you call, ziddi or persistent in whatever they say. And so some patience is required on the part of the caregiver to understand and be caring and say, yeah, please, this is what you can eat and it's good for you or whatever. Because you must understand the caregiver here is often the only sole bread earner, or has to go to work or college, and therefore doesn't have all the time in the world to do this. And it is very, very, very stressful. So thankfully, the at least the psychiatric symptoms are easily controlled. The drugs that are given for other patients are work for HD patients as well, with some moderation or whatever, which the doctor will of course decide. The movement symptoms are, um, for the choreoform movement, they give medication that sort of decreases the movement, the extent of the movement. But it is like you asked, whether it's the diet or whatever you do, it is not going to reverse the condition, but it will prevent very acute deterioration, so that it will slow down the rate of deterioration. So you're kind of uh, what should we say, prolonging relatively comfortable stage by doing all these things. There is a lot of research going on about genetic treatment for Huntington's disease, because it is, like I mentioned, it's a genetic disorder, and gene therapy is being actively considered, and there are drug trials that were ongoing and are still ongoing for different for the Huntington gene itself, where you take repetitive injections and bring down the symptoms. But these are all work in progress. It's still not, there's no drug out there which is ready for use as yet. But there are a lot of drug trials that are going on for small molecule drugs and also for nucleic acid kind of treatments. The big question that many patients ask is about the next generation. So because it is genetic, how what do we do about family planning and things like that. So the other thing is about predictive testing. So like I said, the disease manifests only in middle age, but if I have a parent with HD, should I test myself? When should I test myself? Should I tell children that you may be at risk? When should I tell them this? These are very important burning questions which we have tried to discuss over and over again, because uh, you want to be able to help these families to cope with this problem. So there are centers that offer uh, IVF and testing alongside, so that if you have an embryo that is having the mutation, it will not be implanted. That is an option. Adoption is, of course, an option. The other thing is that you go for a natural pregnancy and test later the amniotic fluid to see whether the child you're carrying has a mutation. But these are all very complex questions which are to be dealt with on a family by family and a case by case basis, because often people think that they can handle bad news. But if you were to test somebody, a young person who is going to go to college or about to get a job, and he or she is asymptomatic today, and if you were to tell them that, okay, can you handle this, and they say yes, yes, we can do it, please, I want to know, and they turn out to be positive, it is a very difficult piece of bad news for an individual to handle. And so it has always to be done with adequate counseling, where the person is in touch with a psychiatrist, because these direct to home testings where you can just mail your blood and you get the report in an envelope or in an email is very, very avoidable for these kind of disorders, because it is not very easy to handle this kind of news. Somehow the human brain seems to think that, oh, I'll probably be negative, but or if it's positive, I can handle this. But when it actually happens, it's not really so easy. So it has to be done very, very, very carefully. Yeah. So Huntington's disease is what is called as autosomal dominant, right? So that means if you have one copy of the Huntington's disease that has a mutation, you're going to get HD. Now, so at the time of pregnancy, you get one copy from the father and one copy from the mother in the offspring, right? So if the fetus inherits the faulty copy from the parent who has the illness, then it is going to be 50% chance. So because you if you were to just do the various combinations that are possible, you realize that there's a 50% chance that the faulty copy is going to come to the offspring. So you will sometimes see that in families, everybody is affected. Sometimes you see that half the kids are affected. There are also instances when nobody is affected. So it is not that 50% of the children are going to get affected. It is that at every pregnancy, there is a 50% chance that the faulty gene is going to get transmitted.